Hello students, this is Dr. Johnson and welcome to this lecture. Again, it's a very important lecture, just like other lectures we've been having in class. So we're going to discuss some of the staffing and the nursing care models that are being used in practice today. So our objective is to evaluate lines of responsibility and accountability that are usually associated with some of these nursing care modules, look at some of the issues that affect how staffing, the factors that affect staffing and their relationship to patient care in different settings, not just in hospital, but other institutions of that patients are in. We're going to look at some of the different characteristics and advantages and disadvantages of each module, and of course look at some of the purpose and components of the nursing care management when it comes to healthcare delivery. So again, with the key terms, these are some of the buzzwords that you might hear or that you might see with NCLEX, so importance of knowing some of these terminologies. So let's start with clinical pathway. Kind of looks at the how some patients' care are actually mapped. So sometimes you may hear them called protocols or care maps or practice critical paths and all that. It's just a way of looking at the sequencing of care when it comes to some patient interventions and their diagnosis and all that. So it's actually the planning phase of the nursing assessment, planning, intervention, evaluation, care of nursing process. So the clinical practice guidelines are actually standards that are prescribed or guidelines that are prescribed to how to treat certain disease processes, so that the way you handle the disease in one setting will be the way we handle in other settings, in other states, because it's a standard set. These are evidence-based, tested interventions that are now grouped as standards. Then you have the nursing care delivery module that it looks at the way work assignments, responsibilities, delegation, authority are structured to help the bedside nurse or bedside provider to perform the tasks that would lead to quality care for patients. Then patient acuity, you will hear this thrown around a lot in staff meetings and all that. It looks at the severity of patient illness. So some patients may be admitted, but the complexity of their care is not as bad as the next patient that may come with myriad of problems and issues that will take the nurse longer time to accomplish. So acuity, depending on the acute or the chronic issues that the patient may have. Then you have patient classification system that categorizes patient according to specific criteria. And then it helps the manager or whoever is in charge that is collecting this data to actually quantify the patient acuity and the amount of nursing hours that will go to that patient. So for instance, if you have a patient that is post-op, that has dressing change, IV care, maybe has vent, maybe has needs turning and repositioning every hour and needs suctioning, that patient will be classified or categorized with patients that will need more care than a patient that just is post-op but just needs somebody to do their vital sign every 4 hours. And then the outcome is, it's again, you're looking at quantifying the data. So you're actually measuring that condition with, excuse me, measuring the condition depending on the outcome of that you're seeking after you put in your interventions and the treatments and all that. So the outcome is what comes out after you did all your intervention. Did the patient get better? Did they get worse? Did they need more interventions, or did they die? Stuff like that. And then the staff mix will be different type of levels of staff that work in a given shift. So it includes not just the RN, but the unit clerk, the nurses, LPNs, medical assistants, who are the people that are in the team to provide that safe quality care so that you have a good patient outcome. And then, of course, we know about unlicensed practitioners. These are the people that assist the professional nurse to do their work in a day-to-day. The professional nurse will now determine who to delegate things to in for the unassisted personnel, depending on the things we talked about in our delegation class, meaning who's capable, who's willing to accept the delegating task, and of course, who the nurse can trust so that quality care is provided. So those are some of the key terms you will hear, buzzwords in nursing, but can also be words that you might see as you take your exams and clerks. Okay, so with the staffing, when a nurse manager is planning staffing, they're planning to make sure that, and again, this is, I always say nurse managers take risk when it comes to staffing, because things can change. The unit can go from being quiet to being chaotic. So the nurse manager always have to keep in the back of her mind that things can change, especially when it comes to her staff and also the patient acuity level. So the things to take into consideration is, what would the patient need? What kind of staff do I have? Are they capable? Do I have the right mix? What is the organizational values or needs? So if it's during joint commission or the state visiting, you will have to take that into consideration, that the organization would like to look good and do well. So staffing mix will change. Maybe the hospital will decide to staff the units with all RNs that week. And also maybe to use mixed group, but mixed group that are well experienced, that can serve patients that week, because the organization or whatever the organization needs are, especially if it's joint commission visit, needs to meet with the staffing level. Okay, so many research have shown that registered nurses are very instrumental in the outcome of patient. So many hospitals, again, cannot practice or open up their doors unless there are RNs involved. Again, depending on where it is. So some units have high acuity level, like ICUs, med-surg, especially med-surg that has high-risk patients pre-op and post-op. So in those cases, RNs must be on the unit. Couple of RNs, because that will reduce it will bring better outcome of the patient final stage. So we're looking at the number of patients that are there and the acuity level. What kind of classification do they need? Higher care or lower care? How are the nurses there? Do we need more experienced nurses, newer nurses, more RNs as opposed to LPNs and nursing assistants? Looking at the environment, again, you're looking at your staffing or the area that the staffing that the nurse manager is staffing. Is it ICU? Is it med-surg? Is it PED? Depending on that, the manager will be able to now know what staff to use. How about technology? You know, you always think of that the technology is doesn't have any impact on our practice, but if you think about downtime when technology crashes, or how many computers, especially cows, like computers on wheels that are available for nursing to input their data, and also how about the medicine staff, do they have enough computer to put in their orders? So all those things can affect staffing. So with the patient classification system, the American Nurses Association uses different factors when this is being classified. For instance, the age and the functional ability of the patient. Younger patients tend to need lesser care than geriatric patients. Younger patients can do their own ADLs or help depending on their disease process, whereas with the older patients, you may need complete care or assistant, but more assistant than the younger patients. Communication skills are also very important, especially when you're talking about patients that have limited English, that can communicate with the patient and with the staff. So the staff always have to be cognizant of using interpreters. This may actually work against time, because by communicating with patients using an interpreter, the nurse have to give more time, especially when it comes to teaching, getting the patient ready for other services. So that cultural linguistic diversity comes into play and also affects the classification. And how about the urgency of the condition? Is it an emergent condition that the nurse needs to react immediately, or is it a case where you can actually prioritize patient care depending on non-emergent care? So if you have a unit where most patients tend to code, then the staffing will be different, because you have to think about staffing that will be able to take care of the codes and staffing that will continue taking care of the rest of the patients. Then you have to look at some of the procedures that the patients are scheduled for. Are these procedures that will take the patient out of the unit? Who will go with the patient? Does it require an RN, especially if it's conscious sedation that is involved, an assessment that is involved along the way? Or could it be done by unassisted personnel, like going to services that outside the unit that doesn't require RN assessment? And the ability to meet the healthcare requisites for this patient, and can the nurse or RN in this case be able to meet all the requirements that the patients need inside the unit without having to go elsewhere? How about the family, the psychosocial and social needs of this patient? Do they need a lot of psychosocial help in the sense of one-to-one and close supervision, because that can affect the staffing mix? How about the needs that the patient and the RNs can identify that can actually stunt the way that this patient care can be done? So all these things, the nurse manager keeps it in the back of her mind as she's trying to staff the unit. Okay, so let's start from there. Okay, so with the part of the staffing that many managers don't take into account is how satisfied are their nurses and how satisfied are patients, because these are some of the things that the Joint Commission is actually looking at when they're doing Praise Genie or HCAPS and some of these and Leapfrog. So some of these stakeholders want to look at how patient satisfaction, because with the patient satisfaction, the staff actually has to be satisfied. So evidence show that satisfied nurses tend to do better, even when there's chaos or that the system is not working. They would make the best of it, because nursing is at the bedside 24/7, 7 days a week, 365 days a year, days a year. The nurse manager has to strive, or not just the nurse manager, the hospital, the administration has to strive to find creative ways to get their staff happy. So for instance, if a nurse, if in group homes, nurses tend to be on call 24/7, but if you can find a way to take away that 24/7 so they can do whatever it is that nurses do after work, like have at least go out and drink with their friends while somebody else is covering their 24/7, so that the next day they can come back refreshed, happy, and willing to give more. So again, looking at different ways to make their staff happy is key to staffing. Looking at organizational needs, again, the importance of knowing what's working at the back end in the hospitals, like financial resources, budgeting, some of the standards that the hospital has to meet accreditation. Again, goes back to patient staff satisfaction, looking at how can the hospital still maintain cost effectiveness while meeting the standards set by these organizational bodies about staffing. So that's why you see 1 nurse to 10 nurses aide, and the reason why is that 10 nurses aide will actually cost you the salary of a 1 nurse. So instead of just having 2 nurses, let's have 1 nurse to be in charge so that we're meeting the state board accreditation, and then use the money to hire as many nurses aides instead of getting another RN. So again, it helps make sure that the hospital doesn't go into bankruptcy, that they're being cost effective, and that because being cost effective, meaning giving more resources to the staff, to the patients. The nurse manager for each unit is actually accountable for the budgeting needs of that unit. So again, when the nurse manager is staffing, she's thinking, okay, this is the amount of money I have. I can't overspend without justification. I have to make sure that I have mixture, right? So this is where they hire other disciplines instead of just RN. And then the most, because RNs are very expensive, so they will make that justification, instead of having 3 RNs, let me get 2 and then hire the rest as nurses aides, LPN, and such. Okay, so let's look at some of the nursing care delivery. Nursing care delivery, as I explained with that key terminology, is that how assignments are divided up among staff, and who is responsible for which task, as long as it's within the standards set by the state board, that we're not delegating nursing tasks to people that don't have license, right? And the caregivers should match the patient care needs. So if I have a unit that is full of high-risk patients, it behooves me to have RNs. And then my justification to the budgeting committee or to my boss, if I'm the manager, is to say, yes, I know I'm going over my budgeting, but look at my patient acuity level or classification level. That's why I need an RN. So always have to justify going over your budget, and always justify why you're not using more than an RN. So there are the classic nursing care delivery models that you see out there, like the total patient care module, the functional nursing module, the team nursing, primary care nursing. And again, some hospitals may adopt variation of this as their staffing. Many nurses have worked in many of these module team, and each one comes with its pro and cons. So let's look at them. So with the total patient care, the nurse is responsible for everything, for the planning, for the performing of nursing care, and that includes making the bed, giving water, doing everything for the patient. The nurse is that. And it's one of the oldest methods, and sometimes you hear people call it as case nursing, but this type of nursing, the nurse is at the bedside. Part of the total patient care is part of learning. So you may see this with hospitals where the student they have nursing students, and they're using the nursing students so that the nursing student can learn every aspect of the nursing. Is it cost effective? Not really. Can you imagine an RN doing everything on top of documenting medication, they're changing beds, they're doing ADLs, they're doing everything. So they will never finish. And of course, it's costing the hospital money. The functional care nursing, these are the staff members are assigned to complete certain tasks for a group of people instead of specific. So it could be like 2 RN working with several other mix of staff, and their job is to, they will probably say, no, we'll complete care as a group to patient A, B, C, D, whereas the other one will be completed with patient F, G, H, so it's not just one specific patient. So the nurse manager will assign the completion of tasks to a group, usually a group led by an RN, and then the RN would delegate the task to the LPN, the unit, the nursing assistant in the unit, and then together as a group, they will now take care of several patients. But again, with the going back to delegation, the RN is still accountable for everything that that group, the team does in that group. So that leads us to team nursing. So the team nursing is almost like your functional nursing. Again, it's a team of staff that coordinates the care of specific individuals. So the RN is always the team leader. She's the person that will be, so they will say we have team A, B, C. Each team A, B, C has a nurse that is part of that team ABC. And then under that team ABC, you will have LPNs, nursing assistants, techs, and each team will work together, just like in the functional nursing, they work together to, again, provide care to certain type of patients. And then, of course, you have an RN that is in charge that the team reports to. So you're kind of like having two charge nurses, the charge nurse for the overall unit, and then the charge nurse for each team. Then you have, with the team nursing is very good because it's, you're dividing work among each other, getting the work done faster and efficiently. The only bad thing is that, some members of the team may not want to play ball, right? So some of them may be lazy, they may not want to do what they have to do. So again, it's important. Many people will shy away from working with those people, or they will have to supervise them better to get those people in the team to be able to do the job that they're supposed to do. The modular nursing is modification of the team and the functional nursing, because in this case, the staff is divided into the same team, but they use geographic location to divide the unit. So in some hospitals that are divided into that, the rooms are in the different corridors, they may say, oh, corridor A belongs to this team, corridor B belongs to this team. The only bad thing about it is that what if more patients are admitted in corridor B as opposed to corridor A? Who's really taking care of? Then the work is not divvied up fairly. So nurses may not like that, because then it looks like people are being unfair to whatever module that doesn't have a lot of patients. Or maybe they started out with the same patients, but then people from module A tend to be discharged, leaving them with maybe one or two, where module B is still hopping with 20, 40 patients. So again, the charge nurse need to step in and maybe divvy up the care, in the sense of saying, hey, team B, you have to now help team A because you don't have a lot of patients. Okay, the primary care nursing is where the nurse assumes 24-hour responsibility for the care of the patient. So even if the nurse is home, she's still responsible. She will have associates. So these associate nurses will help when the primary nurse is off. You probably will see this more in home care and group homes, but I've seen it in hospitals. I've actually been part of it. Hospitals that practice that are going magnet. So like Cornell, they will have primary nurse. So whenever that patient comes into the hospital, let's say the patient comes in once every 5 years, as long as you're the primary nurse, you're getting that patient. And the reason why is that it makes care consistent. So when the patient comes, let's say you're not working that day, your associate nurse will step in, because they, again, know the patient and hold that patient for you, take care of the patient, kind of plan the care for the patient pending your return. Once you return, take over back your patient. So that's how that works. Again, this could be advantageous because the nurse knows the patient and can plan the care for the patient, but it can also be disadvantageous in the sense that, you know, you have to have enough RNs because the associate has to also be an RN. It can be an LPN, it cannot be a nurse's aide. So you have to have enough RNs to be able to pull this off. So it's not that cost effective. So you have the partnership module that the RN is partnered, or they work together with specific staff. So they partner with this staff to provide care for the patient. And again, the RN is still responsible. But what happened with this type of thing is that when an RN is consistently partnered with an LPN and then, or a nurse's assistant, and then what if one day one of them either decide to leave or don't show up or called out sick, the RN now finds it very difficult to now work with, let's say, float nurse or another staff member that is not in that partnership, because they've already established trust with the other one that is not there for that day. So again, it has its advantage and disadvantages, but again, it depends on, remember, it's not just about the staffing different mix that makes staffing, you know, are people happy? Can they be creative? Can they tolerate? Can they be flexible in the way they work? So this partnership nursing module can be very instrumental in, like they say, nursing homes. Okay, so another buzzword you hear out there is the patient-centered care, that every care, and actually we talked about this in almost all the lectures we talked about, especially with the last one about culture, that every care, when you provide care for patients, you should make sure that patient is involved. Number one, they're actually partners with the treating staff. So they can also give us suggestion how we treat them, but also that we are individualizing their care. We're respectful of their preferences, their needs, their culture, their values. They bring it to the table, we look through it and partner with them to decide which one is good that can work with our medical regimen and which one that may be harmful. And then we all have to agree with the patient before this care is rendered. So again, it's a way to bring families to not only to include them, but it's a way to provide them with information that they would need, and for other caregivers to also get this information to treat them, and also to establish that partnership that will help, especially when it comes to decision making, that is not one-sided, that the patient's values are taken into consideration. So patient rights is very important here. There are case management, there are approaches to staffing that is very important. So the collaborative approach is that the case manager, there are many nurses that are certified as case managers, that they work with the unit they have a caseload of patients, that they work with the patient even before they even get ill, to the time they're in the hospital and then to the time they leave the hospital, to make sure that they're getting care that is not fragmented or duplicated, because that's expensive, and that they're not getting redundant care. So because if the patient goes from one hospital to another hospital, the other hospital may have started some type of regimen, but the second hospital doesn't even know about it. So case managers become that person that knows everything about the patient, that can now make sure that other providers know about the patient, and this will stop bleeding of money, healthcare finances on unnecessary procedures for these patients. So as a care module, it's the RN case management is it's actually part of population health management, where you're managing a population depending again on the acuity level and all that. So you see more with patients that are chronically ill, like in hospice or trauma, or patients that have rehab, patients that have illnesses that are very expensive, or regimens that are very expensive. So the case manager becomes involved to find ways to cut down on costs, still maintaining that quality care for the patient. You have different types of it now that is the buzzword in the hospital, like the patient navigators. They're case managers that help the patient navigate healthcare. Some people think, oh, just go to the hospital and call it a day and everything is fine, but that's not how healthcare works. There are so many things that lay people may not know. So the patient navigators comes in, especially when it comes to payments and some of the advanced directives. They can actually be involved with it. They follow the patient from a community setting to the hospital back, making sure that they don't overspend. They spend their time in the hospital or nursing homes, since the community setting is cheaper than those places. So they will strive to get these patients home again under good condition. And then you have the transitional care nurses. With the transitional care nurses, they actually help patients that are chronically ill. They advocate for them to get things that these patients may not be able to get from themselves. So they make sure that these patients they have good follow-up, they take their medication, that they're not over-medicating, their medications are reconciled, that they get the referrals that they need. They encourage patients, especially the patient that is chronically ill, that they can't speak for themselves. The transitional care will tap into family members and social groups that the patient belongs to help to find ways. Hopefully the patient will have advanced directives as they're making final decisions for this patient. The clinical pathways that we talked about, that you talk about clinical maps or protocol, again, helps to tell the practitioner at the bedside how to take care of some of the disease processes out there, so that it's standardized for everybody. So again, this is what I keep telling you guys: if somebody sue you, as long as you're within the standard guidelines of that practice, nobody can really sue you, because you can always use that as, hey, I was meeting standard. This is what standard calls for. So these are the clinical pathways. And again, it's made up of evidence-based research that will have been tested for its validity and reliability, and then it's actually implemented into this evidence-based practice. So if you look at some computer systems, they have this. They will give you alerts, especially when patients will need reweighing, or they may need vital sign. So they will pop up alerts on your tablet or your computer to say, hey, it's been 30 days, this patient will need another assessment, or this medication can be prescribed. So the physician will know, okay, let me prescribe this medication depending on the standard. So again, very important pathway, and it's actually called participatory information, because with the, it's actually not participatory. Participatory is when the patient actually is part of the decision making. But with the clinical pathways, it's part of the clinical decision system that you might see in computers. It's called the CDSS, that you might see built into information system. I think I talked about it in my last lecture. Okay, so what are some of the essential components that clinical pathways must have? They must have all these things on the slide, from physical assessment to labs to demographics to safety issue, nutrition, all those things that we need as we treat patients. It may also address some of the different variations that might happen in response to the planned interventions for the patient. So it's very handy for practitioners when they're taking care of complex patients. But you have to think, does this really tap into our critical thinking, all those things we learn in school? Now we're letting computers make the decision. In a way, it's not, it's kind of cookie cutter type of care, but at the end of the day, we're still the people that will have to make that final decision. So if the computer is saying to us, do this, computer doesn't see our patient. We have done assessment. We know that the standard that the computer is trying to tell us to do is valid, but it may not be valid for that particular patient. So we still retain that critical thinking component. So there are different examples of healthcare settings that require different modules. Again, it depends on whether you use team nursing or primary care nursing, depends on where you work. So I know for team nursing, it's more of your med-surg unit where you have high volume of patients that need different care. So you can use RNs, LPN, nurses aides in a team to get these accomplished. But when you're moving towards ICU, you need total patient care, or even primary care nursing, because there's a lot of individualized critical care into high risk intervention for these high risk patients. So it has to be a nurse that will give the complete care, including bed making, changing everything, because they're dealing with lesser patients but higher acuity level. And then you have the primary nursing, coupled with your case management, with the navigators and all that you can do with home health, right? You don't have to be at the patient's home 24/7, as long as the patient can reach you with, they can call you and, you can reach them or see them once a week kind of thing. So every area you work has different ways of what they're looking for in terms of nursing. So let's evaluate the whole thing. When you're looking at nursing care delivery modules, you're looking at the patient, you're looking at their acuity, their outcome, how cost effective will it be, depending on the type of module you use. Are the patient happy? How about the nurses? Do you have that patient satisfaction, staff satisfaction? How about the other members of the team? Are they satisfied? And does the team allow for implementation of nursing process? Again, if that's not in there, well, I don't know, I can't understand how any nurse will practice without nursing process. But if it's not part of the nursing process, is not being practiced, then it's probably not a good module. And what do I mean by that? That the RNs still get to do the assessment, the planning, the evaluation, the intervention, and all that, and delegate appropriately. And does it allow communication among the team members? Again, when we did communication, you saw the importance of it, that without communication, healthcare team members probably will suffer as they go through some of the interventions that in a day. So sometimes there is perception, there's disagreement, there are conflict. So important, if the system allows for that to happen, then it's a good system. If it doesn't allow for that, then the system will need to be revamped. Okay, so that's the end of the lecture. Please listen to it. It will be part of our exam next week. If you have any questions, please feel free to reach out to me. Okay, thank you. See you in class.